if I can figure out which one it's going to be doing, you should be able to see a slide. Do you see something? Nod, smile.
Yes.
Okay.
Yes.
Yay, rah. Okay. And I'm quite comfortable with people asking questions as we speak. I'm going to try and keep a track of the chat box. And so if you're not comfortable, like, or if you can't get a word in edgewise, just holler and I will look at the chat box and that'll hopefully help me keep track of where things, although for some reason that has just disappeared off. There it is. Disappeared off my screen for a second. Okay, well, as Emily said, I should say we're no relations, even though we have the same last name. Didn't meet till a couple of months ago. But I'm the director at the Spartanburg Area Mental Health Center, and I really want to make this fairly informal. There aren't that many of you, what, 8? If I can count before we get beyond 2 or 3. So please feel free to ask. I'm also going to be really, really rude and try to finish my lunch at the same time because I got myself a little bit behind schedule, as happens. And one of my staff brought a pastel Puerto Riqueño, and we're going to see how well that works. So if I sound like I'm mumbling as I give you the answer, it's because I decided to take a bite. I have worked for the department for about 30 years, which is way longer than I thought I was going to be. When I started, I figured I would be here like most folks, 3 or 4 years, and it's now 30 years later, and I'm still here. I've been here at this office for about 2.5 years now. I was the director of services for the deaf for the 10 years before that. So my regular language is sign, then English, then Spanish, and French, which is the language I think is French, and then as well as a couple of other languages here and there. So, but again, please feel free to ask questions and to just speak up. The department. So we want to talk about kind of the mental health system and how it works. And I looked at the book chapter, and it's pretty basic, and some of that same stuff is here. This is stuff that we know back in the late 1700s. What they figured out was that if somebody was mentally ill, well, and if they didn't have money, pretty bad things happened. If they had money, sometimes they might end up in a private hospital. But by and large, we just didn't have a good system. And if you were poor, you ended up either in a debtor's prison or in a workhouse. Starting in Virginia, I think in 1768, they started making some changes to that. South Carolina was fairly ahead of the curve. 1821, they proposed to set up a psychiatric hospital. Of course, back then, it didn't have that name. It was the South Carolina Lunatic Asylum. And South Carolina was the 3rd state to allocate state funding for the care of mentally ill individuals. And so they started building it in 1822. They didn't actually finish building it till 1828. How many of you have seen Bull Street in Columbia? No, not Julia. She's the only one I can actually see the face of, or half her face after the mask. Bull Street is the big old hospital that is right down on Elmwood. If you ever drive to Columbia, the first building you see right as you get off Elmwood, which is 26, when it splits to 126, and it goes into downtown Columbia, that building you see right in front of you is Bull Street. And that building was built way back in 1822. It was an amazing building when they built it. Even though there was a pretty bad fire there a couple of months ago, it is still standing. It has 6-foot thick walls, so even a pretty good sized fire didn't make much of a dent in the building. But that was, this is a little note about the first patient they had. Not surprisingly, she was female. If you look at old state hospital records, the early 1800s, they were almost always women. uh, they it's always, if you ever get really bored, go find and look at the old records about the reasons people were hospitalized. Um, I, there's a long list available in one place that says that lists she read too much. One read she doesn't read enough. One suggested that she had too many children. One suggested she didn't have enough. Sort of an interesting collection of reasons, but uh, you know, that was a state mental health system through all of the 1800s, was a hospital. And that's pretty much all they did. The hospital expanded. There was some real money problems, obviously, related to the Civil War. And they couldn't figure out what they were going to do. And it just, if you've ever been to the state hospital, or if you know Columbia at all, from where that state hospital is, everything to the south and east of there was all the state hospital. They had a farm and a dairy, and they had their own. They were a completely self-contained community. Nobody else got to go there. It was a very restrictive kind of environment, and that was because they thought that's what persons who had a mental illness needed. That they needed that isolation, and that was the original definition of an asylum. It was to separate people from the rest of society. So that's what they did. And then, you know, it pretty much stayed about the same. They started building a new hospital. Sadly, of course, this is in the days of segregation. They built a hospital just for patients of color back in 1913, and that was out on Crass Farrow, which is the hospital, which is still a hospital. The original, the Bull Street campus is no longer a psychiatric hospital. That has now been closed, and in fact, they're trying to convert it into apartments and all that fun stuff. So, but just kind of give you a brief history of how we got there. So up until sometime in the mid 1920s, they finally said, well, maybe hospitals aren't the direction we want to go. Maybe we should start looking at community mental health centers, which is the focus of this presentation. So they started the first one in 1923 in Columbia. 1924 here in Spartanburg, they set up a mobile clinic. Now, what did a mobile clinic mean back then? It meant that a psychiatrist and a nurse from the hospital drove up here to see patients who had been discharged from the hospital. Because remember, there really was no community mental health system. There wasn't a place where people would go. But they would drive up here and see those patients that they had discharged whenever they had discharged them, and check and see how they were doing. And then they did the same in Florence and Orangeburg and Anderson, and then they finally kind of reached out to Charleston and Rock Hill. But again, these were not they weren't what you might think of as buildings. They primarily were arranged around serving the patients who had been in the hospital and were now living in the community, and just making sure that they were done. And it really, that of course, there was this matter of a couple of world wars, and that kind of made things a little bit difficult. But in 1947, there was a federal law passed to allow for the creation of mental health centers, because before then, another issue was funding. The only mental health care they could pay for was in a hospital. 1957, they actually opened a clinic here in Spartanburg. That was when we actually had a building. Like most of the other buildings, you would have thought it was a house. Basically, they built houses. They bought houses that were on hospital properties. Back then, most hospitals had housing for doctors and nurses. And so they just bought one of those houses here in the Spartanburg area, back in which, to give you an idea of how old I am, that was the year I was born, 1957, when they actually, it doesn't say it here, but I know that the one here in Spartanburg was built at that time, or actually they bought at that time. And that was it was fairly revolutionary for a state to have those kind of systems. South Carolina was one of the earliest ones. And then, as your book referenced, in 1964, the Federal Community Mental Health Centers Act. And that really changed the picture from this idea that, oh, this novel concept of actually serving people. But again, up until 64, it was primarily folks who had been in the hospital and they were trying to help them adapt and help them cope with living in the community. So it was really still, the primary focus was still on the hospital and not on the needs of folks in the community. But that was then. This is now. So since 64, we have rapidly expanded. There were a whole bunch of things that South Carolina did first. DAODAS, the Department of Alcohol and Other Drug Abuse Services, used to be a program of the Department of Mental Health. We were one of the first states to have a drug and alcohol treatment program. DDSN, the Department of Disabilities and Special Needs, was also an outgrowth from the original commission that ran the South Carolina Lunatic Asylum. There were also as those agencies, there was a program for autistic children, which was relatively new. Now, currently in South Carolina, DAODAS is a separate agency, DDSN is a separate agency, and they have care of autistic children. But all of those things were fairly new. And understand the state hospital at that time had a patient population a little bit over 6,000 people. For comparison, now the state hospital has about 450 folks in the state hospital system. So a humongous change from the mid 60s, which was when the peak was. And 6,000 patients, that might sound like a lot. There were hospitals in New York City or outside of New York City on Long Island that had 20 and 30,000 people in them, which were just huge, sprawling facilities. So, there were legislation, the 64, the rehab, the Community Mental Health Center Act. Then in the early 70s, there was some litigation and legislation about people who were hospitalized, and Park versus Pennsylvania is kind of the big one, in which there was a trend towards deinstitutionalization. Now, Park, which is the Pennsylvania Area Association for Retarded Citizens, brought a lawsuit against the state of Pennsylvania and said, you can't keep people in these terrible circumstances. You need to provide training and proper care and treatment. And their hope was to get the state to provide the proper care and treatment. Unfortunately, the side effect was that what happened is states drastically reduced their inpatient populations. So, where you had multiple thousands of people living in a hospital, you went into the hundreds. South Carolina, like all of the other states, made varying efforts to try to meet the needs of those folks who'd been in the hospital and try to provide the care in the community. So we started something called the Towards Local Care Project in the 1980s. We still operate a TLC program here. And the goal is to serve that 6,000 patient, which probably today would be 2 or 3 times that, because certainly the population of South Carolina has grown a lot since the 1960s. And they sort of at the same time, for the first time, Dr. Hall, who had been the director of the department for 30 or 40 years, and like all of the other previous directors, had been a physician. Dr. Bevilacqua, who was not a physician, he's a social worker, took over as the director of the agency in the mid-'80s. And that really changed the direction of how the agency operated, and changed us from a primarily geared to an inpatient setting to being geared to an outpatient setting. It's probably worthy of note that just this year, we had a physician once again appointed as a director, and it'll be interesting to see how the agency changes as we move. That's the first time since 1985, so what is it, 35 years later, we have a doc again as the chair. But so starting in those 80s, they moved patients from the hospital, trying to reduce that population out from the hospital into the communities. We saw the growth of community residential care facilities. You'll hear us often refer to them as CRCFs. So we have staff who work with 3 of the larger CRCFs here in the community and help that population, primarily of people who were in the state hospital at some point in time, learn new skills, try to help them ideally move out from living in the hospital to moving out into the community. It's worthy of note that that's about the time I was hired, 1990. I was hired as part of a lawsuit against the state of South Carolina because deaf patients were not able to participate in that same deinstitutionalization that the hearing patients were participating in. So whereas hearing patients were being moved out of the facilities, deaf patients were just languishing in some of the not the best back wards. And so I was hired to work to identify the deaf patients, get them out of the hospital and into the community. So just at a very personal level, that culminated in '94 with the opening of the first community residential care facility for the deaf, which actually was one of the first in the country. And then subsequently, we were actually able to close that 10 years later and move everybody out to apartments. So that's been the general trend of the department, moving away from that inpatient facility to some sort of structured residential program, and then on to some sort of supported apartments. So we have a bunch of different programs that do nothing but try to help people get out of the hospital, keep them out of the hospital, keep them from going into the hospital, and if they are in the hospital, make that stay as short as possible. When I started, the average length of stay for a hearing patient in one of the chronic units was in the years, and it went all the way down to about 17 days. And it actually has gone up again because what's happening now is the patients who are being admitted to the hospital tend to be sicker than there was a time in the 90s where we would get a lot of people into the hospital for very short periods of time, and that just doesn't happen nearly as much now as it did back then. Now, most of the folks who are ending up in the hospital are quite sick, have probably already been through a private hospital and are into the state system. So, okay, Alexis, Alejandro? I'm sorry, I can't see whose first name that is. Oh, it is Alexia. I don't know what that means, that symbol. You're gonna have to help me out. Oh, okay, that's what that means, nothing. I saw it and I wasn't sure if it was some symbol with which I'm unfamiliar. So as they move the patients out from the hospitals into the community mental health centers also got opening. So there are 16 community mental health centers across the state. This is one of those 16. So we have the 16 centers. We still operate hospitals in Anderson and in Columbia. Columbia, we also operate a children's hospital. Then we operate forensic units, which serve individuals who are either not guilty by reason of insanity or incompetent to stand trial, or are pending trial but are dangerous to themselves or others and need to be hospitalized pending the outcome of their trial. We also operate nursing homes and, as I said, a lot of apartments and community residential care facilities. And then the last inpatient side is a sexually violent predator program. So all of those things are running pretty much kind of nonstop with those 16 mental health centers that we're running. Okay, so what does that mean in terms of just how do we run that many mental health centers? We have clinics in every county. There are 46 counties in South Carolina, for those of you who are trying to keep track of those. This office, for example, serves Spartanburg County, Cherokee County, and Union County. So some centers like Beckman over in Greenwood serves 7 counties. So they've got Abbeville and McCormick and Edgefield and Saluda. I am sure I'm going to forget some. Greenwood, Lawrence, Newberry, and one more that I've forgotten. They serve a lot of smaller communities. A couple of centers only serve 1 county, like Greenville, because Greenville is such a large county, or Berkeley, which just for sort of political reasons ended up with its own little center in one of the smaller centers. Lexington, which also is just 1 county. But all told, across the system, we serve about 100,000 people a year. About 35,000 or so are kids. This center serves a slightly higher percentage of kids. It's almost about 40% of our population are kids. And a lot of that has to do with, as we'll talk about, one of our major service delivery methods is the school-based services, which is where we are serving kids in schools. So that gives us a higher percentage of kids in service. This center serves about 7,000 patients a year. About 5,000 of them are here at the Spartanburg, the main clinic, and then about 1,000 each, which I guess we're probably close to about 5,500 here at the Spartanburg office and about 750 each in the Cherokee and Union clinics. Even though Union obviously is a smaller county than Cherokee, they serve about the same number of people because there are some more resources available in Cherokee County, whereas Union, we're pretty much the only game in town. So that kind of gets us to where we are. So I want to talk a little bit about the services we have, but this is a good time for questions. Everybody alive and awake? I'm assuming that the only one I know for sure is Julia, because I can see her. Did somebody have a question? I thought I saw the.
I'll just ask a question with the when you were talking about the not really mental illness, but with the deaf people, when they weren't getting the proper care, was it more like being unfair, or more like them not setting them up to live on their own?
All of the above. Before I started, they didn't have anybody who knew sign language on the clinical staff. So they weren't able to make accurate diagnoses. So sometimes people were being treated for the wrong illness, which obviously didn't help. And then, so the first thing we had to do was identify the patients and figure out what was wrong, because often the diagnosis that was in the record was not accurate. And then the next challenge was that the outpatient side was not prepared to meet their needs. So we had to hire outpatient staff who could sign. So we hired outpatient staff who could sign. Then the residential care facilities were not willing to accept deaf patients for a variety of reasons, some good reasons, some bad reasons. But so that there was just a complete lack of a continuum of mental health services if you were deaf. And quite frankly, you know, it's a circumstance not unlike what we are facing with the Latinx community now. This mental health center has 11 staff who speak Spanish, 1 staff member who's monolingual Spanish. The remaining are bilingual, Spanish and English. We have 6 staff who are first language native users of Spanish. So trying to get a mental health system up to meet that linguistic minority has also been a little bit of an uphill battle. But in the same way, you know, if the services are not accessible, then people don't get the care they need. And sadly, that means that, you know, in the mid 80s and 90s, it meant people were ending up being institutionalized longer than they needed to be. A whole bunch of other things might happen today, including, of course, law enforcement, all that. I'd have Julia to answer. Sorry, Julia's asked a question whether or not the original institutions were primarily women. I don't know that that is true. The first admissions were mostly women. When I look around state records, I don't know that during the kind of, you know, when they were at 6,000 people, there were, actually, I think there was a majority of male patients at that time, you know, when that time. There's no question that now we are serving a much larger percentage of children than we were. When we started, we didn't serve kids at all. Kids probably weren't receiving services until probably into the 1960s, when the passage of the Community Mental Health Center Act. So the hospitals didn't typically take kids. There weren't kids' hospitals opening up until Hall Psychiatric Hospital opened up, and Hall was a kids' facility that opened up during the time of Dr. Hall, and that would have been in the 60s as well. Alejandro, you're asking, and I hate to say this, I'm not familiar with the term trans institutionalization. So you're going to have to give me a help with what that term means. Either chat box or unmute yourself, but I'm afraid I'm not familiar with that term. Alejandro? Sierra, we are a state agency. We are not the federal government. Federal government does not actually operate mental health services directly. They fund them through SAMHSA, the Substance Abuse Mental Health Services Administration, but they don't provide services directly outside of a few pilot programs. Oh, okay. Alejandro has defined transinstitutionalization as moving clients from one institution to another. I would say by and large, no. The vast majority of individuals were moved out of institutions, out of the hospitals, into the community and into the community settings. So now some of those, you know, it could be argued, and in fact, there's a whole federal definition of something called IMDs, Institute for Mental Deficiency or Mental Disease, that you can't move people into an IMD. So we don't move people into another institution. So by and large, people were not trans-institutionalized so much as, sadly, and I think you see this across the United States, not just in South Carolina, what you see more often is individuals who were institutionalized, who were in a program and were placed, either just put on the street, put in an apartment without sufficient support. A lot of times states did not divert enough resources from inpatient care to providing the support many patients needed in the community. So I don't see, now I will say that probably the one exception to that is that we have seen significant increases in the number of individuals in prisons and jails who were institutionalized in psychiatric hospitals. And as the criteria for admission to hospitals changed, as the discharge procedures changed, there is a we see, I mean, right now, the largest psychiatric facility in the country is, they take turns back and forth, either the Cook County Jail or the Los Angeles County Jail. They have more psychiatric patients in those facilities than any state facility anywhere in the country. So if there is trans-institutionalization, I would say, sadly, it is the transfer of some chronic patients from hospitals to prisons. And so that's something that we are continually working to make better. The average length of stay in state psychiatric hospitals right now is about 40 days. So quite a bit longer than in the early 90s, when it was down to 17 days. So it's still, but again, that reflects more the chronicity of the illness of the patients. Do I feel confident about what we've accomplished? Now, there, Sierra, is a complicated question. We have certainly done a lot of good things. We have certainly made humongous improvements in the process. But I would hasten to add, by no means that we have completed the task. So we have made dents, we have made inroads in some areas, but there is a whole lot left to go. And I want to talk a little bit about some of the things we've done, but I don't want you to feel like somehow we are resting on our laurels and said, hey, we got it done, because we certainly don't. What more do you think will need to be improved? Alexia, if I don't answer that in the next couple of minutes, you can fuss at me, but I'm hoping we'll get to that in the next couple of slides. So here are the 16 mental health centers, just so you know. Are you all in Spartanburg? You all live in, I know you're going to college in Spartanburg. Are you all from Spartanburg, or is any of you from other parts of the state?
I'm from Orangeburg County.
Okay, Orangeburg has a mental health center in Orangeburg. It serves Orangeburg and Batesburg. Oh yeah, Hampton, yes. Alexia, Columbia is Columbia and Fairfield County. So Richland and Fairfield are one mental health center. Actually, we are the fourth largest. We're third or fourth, depending on how you count numbers. But Greenville, Charleston, and Columbia are the largest three. We see a few more patients than Columbia does. So in some ways, we're a little bit busier than they are, but that's because we've got 3 counties. So each of those have a board. Each of those, there you go. There's a wonderful map kind of showing which counties are which, if you want to figure out where you live. Orangeburg and Columbia are both there in the middle. Obviously, we're up there in the top. Okay, so, and the other thing that's probably been one of the biggest changes is that when we first started the mental health centers, like Spartanburg, it was Spartanburg. Cherokee and Union didn't have their own. So the number of clinics has dramatically expanded. So we have ones in every county. And as you can see, some counties have got more than one. Greenville's got 3. They've got one in Simpsonville and one in Greer. Aiken has one. It's like right on the border. It's like East Augusta, whatever they call that part of Augusta that's actually in South Carolina. The map's a little bit out of date because Georgetown has 2 clinics now. Richland has one in Lower Richland, and Orangeburg. No, Orangeburg just has the one. So every county gets to be covered, but then, that's only one way that we provide services. So we have the community residential care facilities. So we have homes in Greenville County, in Columbia, in Florence County, in Aiken County. We have staff who work like here. Not everybody works in this building. I'm going to pick on Emily. She occasionally wanders out outside and leaves the little protected environs of the office. She is working in intensive family services. They are going out. But we also have some staff who actually never come in. We have staff working in the jail. We have staff working in the emergency departments. We have staff, it's just in the next slide, we have staff working in schools. We have staff working in abuse recovery centers. We have staff working in emergency dispatch centers. Across the state, there's a variety of different places where staff don't work in the clinic. With most of our hospitals, this map is also, this is the most recent data that the department has out, but I actually know that these are a little bit outdated. If you were to find yourself in an emergency department, in most counties now, many counties don't have a psychiatrist on staff. Many counties have never had a psychiatrist on staff, but they now have telemedicine so that one of our psychiatrists is available 24/7 to see patients who are in the emergency department, help the emergency department do an assessment, figure out whether or not somebody needs to be in the hospital, needs to stay in the hospital, or whether or not they can be seen out in the community. So we have telepsychiatry agreements with most of the hospitals in our, all 4 of the hospitals that we serve, which are Spartanburg Medical Center, the Mary Black campus for Spartanburg Medical, Cherokee Medical Center, and Union Medical Center. So we have psychiatrists who work out of Charleston and Columbia and Aiken, and some of them work from their home these days with the wonderful joy that COVID has brought to this whole process. And so we can make sure, and this is especially critical for kids, because very few hospitals have a child psychiatrist on duty, like none. Maybe MUSC might be the single exception. Palmetto Richland sometimes, Greenville Hospital sometimes, but we have child psychiatrists who can see patients by telemedicine 24/7. So this often is the only way that a regular general practice emergency department would be able to have a child psychiatrist assess a kid and try to figure out what is wrong. And as I said, probably the biggest change in how we do outpatient staff is by school-based services. We have about 35 school-based staff working out of the Spartanburg office. The majority of them are in, don't ask me why, but Spartanburg has 7 school districts. When you try to figure that out, when you look at, say, next county over, Greenville, much bigger county, has 1 school district, but we have 7. So we deal with the 7 here, plus the 1 in Cherokee, plus the 1 in Union. And we have 35 staff now. We really need about 65 staff. So I'm hoping that all of you, as you go through your schooling and you get done and you get your master's and you come back and work for us, we could hire all of you. Now, this is not a job offer. I have to make sure I don't get myself in trouble with somebody from the state personnel people, but you know, please, as you pursue your studies, and this is embarrassing. I should have asked this question of Emily before I started teaching. Is this a graduate or undergraduate class?
Undergraduate.
Undergraduate, okay.
What do you like many people from your agency get their master's in?
We have, I'm a social worker. Emily is, are you counseling, LPC?
LPC and LAC, licensed addiction counselor.
There you go. So we have social workers, counselors, we have marriage and family therapists. The last time I looked at the numbers, the department is roughly a third social workers, a third mental health counseling, and then a third a collection of all kinds of weird things. We have rehabilitation folks, we get some who have an MED, but focusing in, we don't have many psychologists. Psychologists tend to be a PhD level. For licensure, they have to be a PhD. And most of them work in schools or with the DDSN doing more testing than therapy. So the vast majority of our clinical staff are either counseling folks or social work folks or something else. Because Converse College is here in Spartanburg, we have more marriage and family therapists actually than any other center, just because that's the options we have here. Now, we also have nurses and advanced practice nurses, APRNs, and psychiatrists. So just had to count it yesterday. We have 16 psychiatrists, 4 APRNs, 11 nurses with 2 nurse vacancies. We have 92 clinicians, but we have about 20 vacancies. So we are always looking for staff. Does that answer the question, Sierra?
Yes, thank you.
No problem. So, schools are probably the big thing. So all total, if you think back, even back into the early 60s, the Department of Mental Health was one place. You went to Bull Street if you needed hospitalization. That was pretty much it. So now we have about 800 places where you can get services from the Department of Mental Health. I need to point out that South Carolina is unusual in that all of our services are state operated. In the vast majority of states, the services are operated by a network of private nonprofits, and in some states, even private for-profits, which contract with the state to provide those same services. South Carolina, for complicated and political and all kinds of fun reasons why, but South Carolina is the last state to still be completely state operated. Missouri, Connecticut, Nevada, and Idaho all have a few publicly funded mental health. Missouri. Those states still have some public mental health centers, but they have a mix of public and private. Our neighboring states, Georgia and North Carolina, are all private. So that where we have 16 mental health centers, for example, Georgia has 26 tier 1 centers which serve their entire state. But then they have a network of about 600 private providers who provide a particular service as opposed to a comprehensive service. There are pros and cons to that. I actually think South Carolina does a really good job of, we're kind of a one-stop shop. If you have a mental illness and you get to our front door, we will figure out what you need. I consulted to, for example, the city of Cincinnati for a couple of years, and in one county, Hamilton County, which is Cincinnati, they had 67 different agencies providing mental health services. So for patients, it was a real confusing task to try to figure out where did you go to get help, because you might go to one office for psychiatrists and one office to see a counselor and one office for day programming and a different office for care coordination and yet another office if you needed help with housing. And so I think for a lot of our patients, it's easier going to one place. There are obviously some disadvantages. One of them, I'm not going to put Emily on the spot, but what the heck? She was foolish enough to ask me. She probably won't do that again. But one disadvantage is we don't pay competitively with the private sector. And that makes recruiting difficult. It's part of the reason why we have the vacancies, is because we are a state agency, so we're subject to the limitations. Without going too much on a soapbox, the state every couple of years does this big study in which they try to show that they're paying us too much. And every year the study reveals, surprisingly, they're not paying us enough, but it doesn't change our pay. So that's a battle. There's also just the hassles associated with being a bureaucracy. Sometimes we have a paperwork and a process for just about everything. That can occasionally be a little bit of a hassle. At the same time, having that much of a presence also gets us over the financial hurdles. As we saw during COVID, we were a little bit easier to take. We lost about $400,000 in the first month that COVID hit. We're big enough that we can take a $400,000 hit without having to close down. So good and bad, depending on the day of the week and how you feel that day.
As a side note, there's public service loan forgiveness if you work in the government for 10 years. So if you rack up a lot of loans like I did, then there are some benefits in that area.
Yeah, sort of indentured servitude. But anyway, okay, moving right along. What are the things, and Alexia, you asked, what do you think that we need to improve? So let's kind of start with the things that we're doing well, and those will actually naturally lead to the things we need to do better. We were one of the first states to start telepsychiatry, and then actually it was started through From Deaf Services, because we needed to be able to see deaf patients across a long distance very quickly. Obviously, telephones don't work. Now, the vast majority of the deaf community does use some sort of video phones, but back in the early 90s, that wasn't available as an option. So we started doing telepsychiatry from the hospital, where I started, to identify those patients and get them out of the hospital. But we started doing it from the hospital to the mental health centers. So that was back in early 90s. But now our telepsychiatry program has expanded. And then, of course, COVID just mushroomed that extension of services. We went from roughly 15% of our services being done by telemedicine to right now, it's about 55% of our services. At the height of the COVID, when we did that first massive lockdown, we got up to almost 80% of our services being done by some sort of telemedicine. So that's something that I anticipate will continue, that we will continue to see our services being provided by alternative venues, whether that be our doctors are, for example, seeing kids in the schools. Somebody like Emily is working with a family, excuse me. Somebody like Emily who's working with families, we will be able to see families by video, something that just 6 months ago would have been banned by the regulations. So I expect that those changes will continue. So that's something where I see us being a little bit more technologically comfortable. Also see us branching more into things like social media, marketing, reaching out into the community, something that we're still kind of struggling with that. We want to do it, we just haven't figured out the best way. And in fact, I've got a project just working on a social media marketing campaign, and that's like next week's project, but that's one of the things where we need to make improvement. Click the right box here. Okay, crisis stabilization. This is something that is another area where we are needing to make improvement. We opened a kind of a halfway crisis stabilization center. We call it the Eubank Center. It's actually like in a little building right outside our front door, almost in our parking lot, kind of between us and the hospital. And it's operated more as a drop-in center where patients who have severe illnesses can kind of just stop in and talk to staff who are and talk to peers. Our center is the leading center in hiring peer support staff. So these are staff who themselves have a mental illness and are in recovery and can kind of, have a conversation about walking a mile in my shoes. So we have we'll have 7 peer support staff working here, and some of them work at the Eubank Center. So if somebody is having a hard time, they can just kind of sit there. It's not a clinical intervention. It's more designed to be a calm and reassuring place. We eventually would like to get that to a 24-hour crisis stabilization unit. Our goal is across the state to have crisis stabilization so that people who are in psychiatric crisis but don't need a medical intervention, so that they haven't hurt themselves, they haven't overdosed, they haven't attempted to kill themselves, they aren't to that level of needing a medical care, but they need a safe environment that's available 24/7 for some short-term respite, if you will. We have one of those in Charleston, and our hope is to identify the funding to run more of those. But yes, what are the things that need improvement? That is definitely one, is getting that from right now it's a 12 to 9 o'clock at night kind of thing, but I'd eventually like to get it 7 days a week instead of 5, and then to 24 hours a day, 7 days a week. We are, our state is unique. We have an electronic medical record. Now, if you ask Emily on a day when it's not working and she's trying to enter notes, she will say bad words about our electronic medical record. She will mutter under her breath, as we all do when that happens. But the advantage is it was kind of our own, so it's a little friendlier to clinicians than some of the other programs that are out there. But the big thing is it means that a patient who's in Charleston and comes up here, we are all one record. So we have access to everybody's records across the state. That really makes life quite a bit easier. Where do I think we need to make improvements? If any of you have been to a physician in the last couple of years, you probably had access to some sort of patient portal. I'm a patient at Mayo Clinic up in Minnesota. I can access my records from here. I can look at my scans and my labs and, talk to the researchers and try to figure out what's going on with me. I can do that from here. We don't yet have a good patient access to our records. Some of that is because there are some heightened rules about privacy when it comes to psychiatric records. So there's an extra couple of stumbling blocks in that process, but that's something where I'd like to see us make improvement and make that a little bit friendlier. We are still arguing with different people about having email and text access to patients, to clinicians, to records, to information. And that's something where we're still trying to figure out what's the best way to get that done. Kind of talked about school-based services already. That gets funded by the legislature, gives us some money. We also get money from the school district. We bill insurance, we bill Medicaid. We will do whatever it takes to make that work as a financial self-supporting program moving forward. What needs to be improved was we need to be in every school. We originally had a plan to be in every school by 2023. I will tell you that COVID has probably set that back at least 1 year, maybe 2 or more, depending on what kind of long-term financial damage we see coming from the pandemic. But that's an area where we need to see growth. We need to be more in more schools. And obviously, one clinician in a high school of 3,000 students is woefully inadequate. So it's not just one per school. My guess is that over time, that number will probably approach for us closer to 100 plus of individuals being based at some school. So there are some things that we do really well. The youth suicide program, and I should point out actually that starting this year, we got another grant, and it's not just youth suicide, but it's all suicide prevention. So we have a fairly large footprint in the suicide prevention field. I'm sure you've all seen the phone numbers to call for help. In South Carolina, it used to be if you called that number, less than 20% of the calls were answered locally. 80% of the calls were answered on a nationwide basis. That has flipped, and now over 80% of the calls are handled locally. So if you call that number, one of our staff 24/7 answers the phone. They try to figure out what you need. And if you need to have somebody come to your house, well, then they go to your house with law enforcement, because of course we don't know what we're walking into. So our mobile crisis response teams are available 24/7. They reach out to the community. That's another area where I think we need improvement, is working with law enforcement, making sure that law enforcement calls us anytime they go out on a mental health call. They're getting better at it. They're developing trust in us, knowing that we will be there when we call. but trying to figure out ways to make us there a little bit quicker. Because right now, for example, I sometimes work on the mobile crisis team. If if I got a weekend where I'm free, I'll sign up, take a shift. But it still might mean it might take me half an hour to an hour to get to some of our locations. And for law enforcement, that's too long. So trying to figure out ways to identify the funding. So we have staff who can ride along and be embedded in law enforcement 24/7 so we can have quicker response. But our goal is to reduce the rates of suicide. A lot of people think of suicide as a young person's disorder. Sadly, what we actually know is that the rate of suicide is actually highest for middle-aged and older white men. Folks in my group, for specifics, although we certainly know that younger people attempt suicide more often. So our goal is to both reduce attempts, but also to reduce suicides. So that suicide prevention is a whole bunch of things. One of it is our training with law enforcement officers. We do training with them. It's called CIT, Crisis Intervention Treatment. The schools in South Carolina, and Spartanburg has been one of the leaders in doing that across the districts. They do a lot of suicide prevention workshops for staff, for students, to help the schools know how to respond when they have a child who is talking about killing themselves, or if a kid says, I know a friend who's talking about it, whatever, knowing an appropriate way to intervene, knowing how to react and how to respond to the situation. We are having a little bit of a challenge in that right now we are seeing from COVID, the stress of COVID, I think also combined with the stress of racial tension, with the killings of George Floyd or Ahmaud Arbery or Breonna Taylor. We see that adding to stress. We also see, quite frankly, the stress of the current election and all of the chaos and commotion about that. We're seeing an increase in both admissions. We're seeing more patients walking in through our door. We're also seeing an increase in suicides. And so last 2 weeks ago, we had 11 kids sitting in the emergency department with us trying to figure out what do we do with that population, because there just aren't a lot of good resources for kids when we get to that stage, made worse because the one child hospital that the department operates is on lockdown and quarantine because of COVID. So if you want me to fix things, there would be another thing on the list, Alexia, that we need to improve. We work with the Children's Advocacy Center. The slide is about the one in Columbia, but we also work with the one here in Spartanburg. And that's something that we're always trying to improve our relationship with them and make sure, DSS has changed its rules so that if a kid goes into foster care, they're required to bring them into the mental health center and get them assessed and make sure they don't have unmet mental health needs. And as I think it was Alexia, but it might have been Sierra asking about kids. Who was it who asked about kids? Somebody, Julia, I'm sorry. Julia asked about kids. Yes, I've worked in some states where there was no children's mental health services. The public mental health system didn't provide for them. But Emily works for us in our CAF department. So we have a large children and adolescents. It's a little bit, it's almost 50% of our staff work in CAF, and about 40% of our kids are 40% of our patients are kids. So we have several initiatives working with kids. We are trying to get a systems grant, meaning trying to work with the rest of the schools and physical health providers, pediatricians, et cetera, trying to make sure we don't have dropouts between different service providers and making sure that we have what they call a no wrong door approach, meaning that no matter where you go, you'll get the help you need. All right. Just one example of that is something called PCIT, Parent-Child Interaction Therapy. Not something we are yet available. Once again, areas where we need to be improved. We are continuing trying to expand our pool of clinicians trained in a variety of different techniques. We did EMDR, eye movement desensitization, and recovery response, excuse me. We did that last year. We trained about 30 odd members of our staff in EMDR. Emily, did you do the EMDR training?
Yeah, I went through, I'm certified.
Yay. This year, our big push is for DBT, dialectical behavior therapy. Emily, once again, is a champion for DBT. We won't say how long ago I did my DBT training. Let's just say Marshall Linehan was one of the trainers. So, way back then. PCIT is probably one we'll probably be hitting up next. We started talk with a couple of providers to see if we can be able to do that. A lot of these evidence-based training, one of the big challenges is figuring out ways to pay for it, not just pay for the training, but pay for the way that the services have to be delivered to meet the rigorous requirements of that evidence-based approach. So you'll hear, if you ever work in mental health, you will hear all kinds of alphabet soup about different therapy approaches. There is never a shortage. Yep, TheraPlay is one. We have several staff who do TheraPlay. That is. I'm trying to think who else does TheraPlay. Do you do TheraPlay, Emily? You are muted, Emily. You're still muted.
Muted. Okay, so I'm not formally trained in TheraPlay, but I've done my own research and looked through it and self-trained, but not formally. But if you're paying, I would love to do that.
Put it on your training plan for next year.
Okay.
I'm mean and rotten as a director. I make everybody do a training plan, but we do pay for training. So that's a possibility. You guys are all going to be her witness when I go, I can't do it next year. She's going to make you all come and say, but you told her she could. I would be remiss if I didn't talk about programs without talking about deaf services. South Carolina has been the nation leader in providing deaf services. We've written the national model. We have established standards, and we were the first state to totally get everybody who was deaf out of the hospital. We were the first state to set up our specialized community residential care facility, and then the first state to close one down because we got all the patients out of that residential care facility. So we use a lot of telemedicine. As I said, that was something we started in the deaf program. We also do video text and a bunch of other technical toys. I kind of laugh. My family is deaf. I'm the only hearing person in my family. That's almost true. My two eldest children, we had 2 hearing children and 4 deaf children. My 2 eldest children are hearing, but we got rid of them. They're living on opposite sides of the country. So deaf people had video phones and video apps on their phones before hearing people did. So it's kind of funny for me to hear about people using some of the video apps that we've used in the deaf community for many years. So, we talked a little bit about housing. Here are a couple of examples of typical apartments that we operate. Here in Spartanburg, we operate a housing complex called, I know where it is. I know how to get there. Draymont Apartments. We operate Caps Villa Apartments. We have housing arrangements with the Housing Authority at Victoria Gardens and at Halton Place. So we have a variety of different apartments across the county. We also fund and assist patients who need help with paying rent. So we pay 30% or pay a rent subsidy, so they're only paying 30% of their income for rent. So our goal is, if any of you have read the 2020 mental health plan, the goal was by 2020, which is now, we haven't quite got there yet, but the plan was that for everybody who wanted it, who was a mental health patient, to have a job, to have a place to sleep, and in the words of the report, a date Saturday night. Well, we may not necessarily help them get a date Saturday night, but we do want to make sure that they have a job. We have our own vocational program called IPS, and a place to stay through either one of our apartments or through housing subsidies. And that gives you more than you ever want to know about all the housing subsidies. Again, the state funds that because it's a whole lot cheaper to put somebody in a department for a year than one day at an emergency room. An ER visit's $5,000, so or more. So if we can keep somebody out of the hospital, definitely a better plan. As I said, we try to make sure they've got a job. If any of you are familiar with vocational rehabilitation, that's the kind of the default program for people to be in job placement, but that's kind of focusing on finding that perfect job for somebody. My guess is if any of you, whatever your first job was, probably wasn't a job you thought you were going to be in forever. For me, it was being a dishwasher in an Italian restaurant. So that wasn't where I thought I was going to end up. And indeed, it was not where I ended up. So the IPS program is kind of modeled more after that. Patients walk in, say, I want to work. We find them an entry-level job that may or may not be one they stay in for very long, but it just gets them get their foot in the door. And I guess kind of the last piece of that is we are increasingly being a trauma-informed program. We are recognizing the adverse child experiences that most of our patients have had. The vast majority of our patients have been victims of abuse, whether that be physical abuse, sexual abuse, neglect, exploitation, a whole range of things. And so making sure that our system recognizes that and responds more appropriately is an ongoing element that we want to make sure that we are sensitive to that and do not re-traumatize patients. So we talked about DBT, already hit that. That's a particular kind of therapy. It's a cognitive therapy, but it's designed to help people be conscious kind of their own emotions and help them figure out how to cope with those emotions and regulate them in a more effective way. And I've talked about towards local care. That's the thing where we get folks out, put them in the community and try to keep them out there. Okay. 2:40, I think the class goes to 2:45. Yes, okay. I wanted to give everybody some time for questions. This is your chance. That thing you've been burning and haven't been able to sleep for weeks, not knowing the answer to when it comes to community mental health. This is your chance to ask. Don't all talk at once.
Roger, over the years that you have worked at mental health, have you noticed a trend in the diagnoses or the types of problems that present from one generation to the next or from one decade to the next?
I think what I am seeing is probably an increase in the number of patients we see with depression and anxiety. There was a time when we were primarily focused on individuals who had major psychotic disorders, so schizophrenia, the psychotic side of bipolar disorder, schizoaffective disorders. We are seeing as it becomes more acceptable to get mental health treatment, as equity goes into effect. There was a 2005, there was a parity law to try to make insurance coverage for mental illness and physical illness essentially the same. And so all that changed, and people are laughing in their hallway. We do allow people to laugh here once in a while. But as that has changed, I think we are seeing more individuals coming in, and I think anxiety, even more than depression, we're seeing more. And there was a thought I had that has absolutely escaped me. I think the trend that you're going to see in the next couple of years is also us talking more about mental health as opposed to mental illness. You know, the mission of this agency is the recovery of people with mental illness. I wouldn't be surprised if in the next year or so you see a change in that mission, that our goal is to enhance the mental health of people living in South Carolina. So it's not enough to just work with people when they're sick, but try to work with people before they get sick. So we have spent Alexia, another area where we need to get better. We haven't done a good job with prevention and primary care, trying to prevent people from becoming sick in the first place. So I think that's going to be a focus over the years. Well, I have appreciated the fact that at least some of you have stayed awake for the whole time. I can't speak to all of you, but I know poor Julia has, because once again, her face is on the screen. So I keep picking on her, and I apologize for that. I appreciate everybody's attention. If you do have questions, Emily knows how to find me. She's only 2 floors down, 1 wing over, not that hard to find, and I know how to find her. So if you do have questions about the department, as you get through your schooling, if you do find yourself at a graduate level school, please consider us for an internship. And we certainly would love to have any of you come and join us when we're all said and done with this.
Thank you for talking.
Oh, you're welcome, Sierra. I'm pretty sure Sierra is still awake for most of it, unless she fell asleep and woke back up again.
I have one question. With the you do work with mentally ill patients, correct?
Yes.
Do you guys do any like volunteer works or anything like that?
We do some. That's probably an area where we're a little bit weak, to be quite frank. If you are interested in volunteering, we do have Andrew Job coordinates our volunteers. If you are, we have some volunteer opportunities. I need to make sure you have to be 18. I don't know how old you are because I can't see you. So
I'm 21.
Okay, fine. Just want to make sure you have to be 18. But we have used some volunteers in our TLC program and in our Eubank Center at the Peer Drop-In Center.
Okay, so TLC, and then what's the other one?
The Eubank Center, EUBANKS, the Eubank Center, the Peer Drop-In Center.
Okay.
We have some volunteers there as well.
So Andy's in charge of that?
Yep, Andy is the one supposed to be keeping track of that.
Okay. So if you guys are interested in getting in touch with him, he's actually 2 doors, or used to be 2 doors down from me, so that I can link you guys up if that's something you're interested in looking into.
As Emily suggests, we move offices on a weekly basis so that nobody knows where to find anybody.
Yeah, that's exactly right.
Well, it's 2:45. So thank you all for your attention. And if you do have questions, please let Emily know. She knows how to find me.
Thank you again, Roger, for your time this afternoon. I thank you all who came and listened and asked important questions. I appreciate all y'all, and I hope you have a good rest of your evening.